Hi, I'm Helen Bauer, and this is the Heart of Hospice podcast. The Heart of Hospice podcast is your source for compassionate and informative discussions about hospice and end-of-life care. I'm a certified hospice and palliative care nurse with over 15 years of experience. Whether you're a caregiver, someone with a serious illness, or you simply need to know more about hospice care, this podcast is for you. Join me as we explore all the aspects of hospice, from the details of caregiving to the emotional and spiritual dimensions of end-of-life journeys. For more resources and to connect with me, visit theheartofhospice.com and find us on Facebook, Instagram, and LinkedIn. Keep listening for today's episode.
This is the Whole Care Network. Helping you tell your story one podcast at a time. Content presented in the following podcast is for information purposes only. Views and opinions expressed in this podcast are solely those of the host and guest and may not represent the views and opinions of the Whole Care Network. Always consult with your physician for any medical advice, and always consult with your attorney for any legal advice. And thank you for listening to the Whole Care Network.
This episode is sponsored by Hospice Navigation Services. When you need information about hospice, Hospice Navigation Services can help. Our team of experienced hospice navigators is here to offer one-on-one consulting sessions by phone or video. You can book a complimentary 30-minute session when you need general information, or book a 60-minute session when you have in-depth questions or need to troubleshoot your current hospice care. It's your journey. Hospice Navigation Services can be your guide. Visit theheartofhospice.com to schedule your hospice navigation session today.
We're getting back to the basics of hospice care in today's episode, talking about continuous care, when it's used, and how it works with Gabby Jimenez of the Hospice Heart. My guest today, or really my co-host today, is Gabby Jimenez. She's a hospice nurse and an end-of-life doula, a death and dying educator, and an author. She's been at the bedside of over 2,000 people who have taken their last breaths. And she's found that there's a lot of uncertainties and fears that happen when someone is dying. Her end-of-life doula training has helped her to truly understand the sacredness of death and dying and what it means to be present for someone during that intimate and final moment. You can connect with Gabby, the Hospice Heart, at her website, thehospiceheart.net. We're going to be unraveling the mystery of continuous care today because it's a mystery, even at times to me. Gabby and I are going to be talking about what continuous care is, how it's utilized, and who provides it. You're going to hear a little bit of billing information and regulatory information. I'm trying not to lean too heavily into that, but it is sort of interwoven into how continuous care is structured. So listen for the myths. Be sure and hold on to the truths about continuous care, those facts that are so important to know. There's a lot to learn. Gabby, the Hospice Heart, welcome back to the podcast. It's so great to have you with me again.
Well, thank you very much. I'm happy to be here.
We're going to have to put you on the payroll.
I'm all right with that.
What is this, like the fifth or sixth time you've been with me? I love it.
Honestly, I think it's been more than that because there were the ones that we did in pieces, with different members of the hospice team.
Yeah, the series that we did. I got to tell you, this is probably, I wouldn't do this conversation with anybody but you because we're talking about continuous care today. And it is a sticky, kind of complicated topic, and I've been dreading it. But I know between the two of us, we can tackle it. You're going to bring the clinical side. I'm going to bring some of the regulatory, not too much of it, but some of the regulatory pieces. And we are going to really put together this back to basics episode on continuous care. I'm dreading it a little bit, so we're gonna hold each other up on this one.
Well, my hope is that we can help remove some of the confusion. I think people have some misconceptions about what continuous care means.
Yes.
And I think they also aren't certain about the benefits of it as well. And so maybe this is an opportunity for us to clarify and educate all at the same time.
I love that. So we're going to start with the name, because I think continuous care is a misleading name. It's not great, but let's define it. So first of all, continuous care is a level of care inside hospice care. It's not a place. It's a level of care that actually has more to do with billing than anything else, and how the care increases. So it's considered what we call in hospice a higher level of care. Just means the patient has more acuity of symptoms. So what is continuous care used for, and what does that look like?
Well, I think I'll give you an example of when it comes into place. So I'm with a patient. The patient has symptoms that I'm trying to manage, but it's not working. And maybe we need to start giving medications scheduled, or we're going to keep trying to do things at the bedside to reduce the symptoms. And so I'll call the doctor and he'll say something to the effect of, I think it's important that we start continuous care. And, first of all, I think families think, oh, now we have a 24/7 nurse. That's not what continuous care is.
Yeah, I need a buzzer for that one.
Right. And I think what people don't understand is that really what it is that this means that we need to spend more time at your bedside to reduce the symptoms that you're having, to use all of our tools and experience to find a way to bring some peace to this person, to remove suffering. And it might take more meds. It might take positioning. It might take time. Sometimes patients are alone and don't have family members to help with this. Or they might be in a facility where the staff cannot give that time to it. Maybe there's someone there who can't give those medications. Maybe they're not licensed to. And so if medications need to be given until that person becomes more comfortable, someone has to be there.
So most of the care that we provide is in a patient's personal home, personal residence. So when you have a caregiver that can't keep up with the frequency of meds, or sometimes there's a need for titrating the meds up to increase the dosing to try to get those symptoms under control. And we don't just immediately jump to the highest strength of a medication. We do it in small increments. So sometimes those dosings need to be every 30 minutes or every hour, which can really take a toll on a caregiver. Even if there's more than one, it's like running a little hospital for one person. So having continuous care in there can really be useful at those times when it's just too much for a caregiver, but it doesn't justify being in the hospital.
That makes sense. The other thing is routes too, right? Like you're giving these liquid medications in the mouth and it's pooling out and they're not taking it in or whatever. So maybe we'll consider rectal administration of whatever medication might be given. The family will not want anything to do with that. The other thing that freaks people out is you'll draw up, say, 1 ml of morphine, for instance. Well, that's a full syringe of morphine. But we know in this field that that's not very much. And then they want to know, but why is this every hour on the hour? Well, because we need to see how it works for them. We need to watch the effectiveness of those medications. But there is so much fear and misconception about medications that part of this role is not just to reduce symptoms, but to educate and support those at the bedside, either to train them and help them feel more confident to do it, or to explain what is happening. But medications do not work the same way in each human body. And that's another misconception. Oh, well, just give them this. It worked for my sister.
Right.
That is not a guarantee. So yes, we have to keep titrating, as you said, maybe up the meds, maybe start every hour and then move to every 3 or every 6, depending on how they're responding. But what if they don't respond well? What if we need to change the medication? This is where continuous care is so beneficial, because it's this continuous monitoring of a person, their experience, their symptoms, and everything that is happening in that space.
Right. And then you have that nurse at the bedside. So say you've given that new dose twice and the symptoms remain the same. The patient is still in pain or very short of breath or very agitated. Then a nurse is there to immediately assess that it's not effective, can call the doctor immediately instead of the caregiver having to monitor and decide, should I call the nurse? And then the nurse having to call the doctor and get another order. And then the nurse having to call the family back and give new instructions for new meds. Having a continuous care nurse there streamlines that process so that response to the uncontrolled symptoms happens much faster.
I call it time management. It's symptom and time management. Having that nurse at your bedside reduces the time, because it could take, you just described a situation that could take 45 minutes to an hour, sometimes longer.
Yeah, and if you want to add another med, getting it out there.
Right? Or just get some advice. You call the hospice calls the doctor reviews the case. I mean, all that takes a while. Then you arrange for a nurse to go out, or let's say the medications you're wanting aren't in the house. Right. Those have to be ordered. All of this takes time. With continuous care, you have somebody right there that can monitor and manage the symptoms in a way that is far more effective time-wise, but also can reduce the suffering physically for the person in the bed, but also for those having to witness this. Having that person there is the difference between pain and peaceful.
Absolutely. Oh, I like the way you said that. It's the difference between pain and peaceful. Very nice. Okay, so what are some of the symptoms that we would use continuous care for? Pain is obviously a big one.
Pain is definitely a big one. And just from my experience, in most cases, not all, but in most cases, pain is actually easier to manage than agitation and restlessness. And just that whole turmoil that the body is going through, and terminal delirium, and just that mental reaction, the mental, the emotional, and the physical reaction to a body that is trying to die is big. I mean, I've seen patients throwing themselves out, off the bed, or just becoming bigger than life, which no one can truly handle independently.
The behavioral stuff, I think, is way more challenging than the physical stuff.
Absolutely. And you have a caregiver. A good example is a caregiver that's been taking care of this person for a few years, right? Knows them really well, has walked them, fed them, bathed them, and then things change, which we've all seen in this field. This is what happens at the end of life. That caregiver cannot align their care to that patient's needs, and it becomes scary. Yeah. To watch someone you've cared for, and the family goes through this as well. They become angry. They become bigger than life. They become, and some use the word monster or even zombie-like, where they're completely out of control. How do you manage that? Well, it does take, and I'm not a big pusher of medications unless needed. These are those cases when they are definitely needed, and you need someone there to manage them and figure out a plan of care that truly will reduce it.
And so where you're going with that conversation is for palliative sedation. It's a form of sedation that's used to manage these symptoms where nothing else seems to be effective other than helping that patient to sleep through the whole thing using sedation. It's only used when absolutely necessary because it does completely incapacitate the patient. Right. But that is something we do in continuous care as well. You have to have a nurse to help manage that. You have to have a nurse for that. So agitation, Shortness of breath is another one that we use continuous care for. And where I have seen that get complicated for caregivers is we may be giving multiple routes. So we give morphine under the tongue. If the patient can tolerate it, we do inhalers, right? A lot of patients towards the end of life can't do inhalers because it takes some coordination and, of course, the mental acuity to be able to time the breath in with the shot of the inhaler. But we also may be giving breathing treatments as well with albuterol or different bronchodilators, in addition to putting morphine inside a nebulizer. So that kind of caregiving burden for medications becomes overwhelming and not a realistic thing for any caregiver to do. That's another situation where continuous care might be really useful.
I have honestly never used an inhaler or morphine via a nebulizer, but I like the idea of that. I appreciate where that's coming from.
It's an off-label use. And most of the research, from what I remember, is anecdotal. And you don't get as high an absorption when you put morphine and you use it nebulized. If you use it in the nebulizer, it's about a 40 to 45% uptake. So you're losing some of the efficacy of it. But yeah, it can be used that way.
Well, it makes sense because of its method of action. It would open up the lungs to make more room and strength for breathing. So that makes total sense.
Well, and it's quickly absorbed too.
I really like that. Thank you for sharing that. Palliative sedation to me has to be explained so that people understand that it is not temporary. Now, we don't use palliative sedation to hasten this death or to end a life. We use it in the event that medications we are trying are not working because this person is dying. They're already dying. They're just doing it in a way that is incredibly uncomfortable. And so palliative sedation, it removes a portion of the dying process by getting them to a sedated place so they are not physically reacting to everything that they're going through. But it doesn't just magically end their life because you've done this. This could take days. And I think that's another misconception. You're doing palliative sedation. They're totally sedated. Why aren't they dying? They've been doing this for 3 days. Right. The thing that we need to make clear is that the body knows what to do. And depending on how strong, especially their heart is, all those meds can get them to a deep sedation, but will not just end their life because that is not the intention of it. The intention is to sedate them enough to where they are no longer reacting to what is going on with them. They still need to go through the dying process, and that could take time. I've had patients on palliative sedation that died several hours later. I've had some that stayed somewhat cognitive for a little while. I've had some that took days and days. This is just like life and death, cannot be predicted.
Right. And nothing that we do inside continuous care is about hastening anything. Actually, nothing in hospice is about hastening death for sure. And not every patient that has continuous care dies in continuous care. Some of them, the symptoms resolve, the medications are changed and maintained at a more appropriate dose to manage the symptoms. The patient stabilizes, and then the continuous care is stopped, and they go back to the way the hospice care was being given before. The routine home care is what we call it. This conversation is so good, but we're going to take a quick break. Hang on for more great content.
This episode is being sponsored by Hospice Navigation Services. Hospice Navigation Services can provide the answers and support you need, whether you're seeking information for yourself, a loved one, or someone in your care. Our experienced team offers personalized, unbiased guidance through one-on-one consulting sessions by phone or video, tailored to your unique situation. Let us help you navigate hospice care with confidence and compassion. If you're a healthcare professional, Hospice Navigation Services is your trusted resource for you and your clients, providing compassionate, knowledgeable support at every step. When clients or families have questions about hospice, or if you need expert guidance to support your client's end-of-life care decisions, we encourage you to refer them to Hospice Navigation Services. So whether you're exploring how to start hospice services or need to troubleshoot your current hospice care, Hospice Navigation Services is ready to guide you. You deserve clarity and compassionate support on this journey. Visit hospicenavigation.com to schedule your hospice navigation session today.
So I want to talk about a little bit of the business side of it, right? So the first thing for a Medicare hospice patient, it doesn't cost the patient or the family anything to have continuous care start for the patient. It's a really more of a documentation and billing thing on the side of the agency, and it's confusing. One of the requirements is for the agency to be able to bill, there has to be 8 hours within a 24-hour period. But the regulation does not say that you have to do it 8 continuous hours. This is why I don't like the name. Some agencies call it crisis care, which I think is much less confusing.
Well, it makes more sense.
It really does.
Continuous care gives people the impression that this is going to keep going until that person takes their last breath, and that's not necessarily going to happen.
Right, and we already have that misconception about hospice agencies anyway, that when hospice is started, they're going to put somebody in your home to stay with your person for however long, for extended periods of time, and that's not how we do things. We are not set up that way. So if your continuous care needs to be split, so say you have a caregiver that can come in during certain hours, but then they have to be away for work for certain hours. Continuous care can run from 8 a.m. to noon, and then from 4 p.m. to 8 p.m. As long as there's 8 hours in the day, then the agency can bill. And the only reason I bring that up is because we don't talk about billing on the podcast. Billing is painful. It's also not my area. And I don't think field staff or caregivers and patients need to know so much about the billing side of things when it comes to regulations. But if you are going to be scheduling continuous care for your loved one, or you're a hospice team member who's helping to be part of the continuous care team, it's good to know this stuff about how the regulations and the payments work.
Well, and that also, in relative to symptom management and continuous care, yes, a nurse needs to be there, but the continuous care 8-hour requirement doesn't necessarily have to always include a nurse.
That's true. It can include an aide. 50% of it has to be done by a nurse.
Yeah.
But so here's the caveat behind that. If you are giving medications because your patient is in a crisis, right? That's what we're out there for. Most of the time it involves medication changes and administration. An aide cannot do that. They are not legally, not in any state, allowed to administer medications, nor can anybody else on the hospice team. So that is always going to involve an RN or an LVN.
Absolutely.
One of the things I would like to highlight is if you are listening today and you are a caregiver or someone who is trying to educate yourself about hospice because someone you know or love needs hospice care, if you are talking to a hospice agency and they tell you, we don't do continuous care, don't sign up with them. First of all, they are required by regulation to furnish continuous care when needed. Some agencies are unable to staff it because of where they're located, right? Rural agencies have trouble getting staffing, and short staffing is an issue all over the United States these days. However, agencies are required to furnish continuous care, and if they tell you they do not, there's a problem at the agency, and you're probably going to want to talk with another agency instead of this one.
I love that you said that, because that to me rings a bell in my head that says staffing is their biggest issue, which indicates to me that they will not have the manpower to take care of me or my person. So
Right.
if they say no to that up front, what does that mean? So I like that you said that. I think that is important that they, you may not need that, But you need to know that when you sign up with a hospice, that you have all of their resources. And you need to know that information.
Yeah, and you deserve to have an agency that can offer you all of these different things that you're entitled to under the hospice benefit, the Medicare hospice benefit, and continuous care is just one of them.
I also like, going back a bit, I really like when you put in the part about it doesn't come out of pocket. The first thing a family thinks when you say, well, we'll just, stay here for a few hours and see what we can do with titrating the meds and whatnot. Their first thought is, we can't afford this.
Yeah, how much is that going to cost me?
And unfortunately, that is a heavy weight that so many people carry relative to the dying process, is how much is the care going to cost?
Right.
And to be able to relieve people of that burden and just to say, trust us, we can be here for you. This is not going to cost you. Let us figure out what this person needs.
Right. This is part of the service we provide.
Yeah.
Yeah. Oh, okay. I don't think we did so badly. This is a hard topic.
It's a really hard topic.
It is. It is. What else would you want somebody to know about continuous care?
When I am sitting at the bedside with someone and I'm doing my best to reduce their symptoms, I am usually successful. But I am also sometimes not. And that puts me in a really uncomfortable position. As a clinician, I am so thankful for continuous care because it allows me the luxury of time to be there to do whatever I possibly can to reduce this person's suffering and the emotional suffering that the family's experiencing. That's a gift to me that we can offer that. And the benefits can often, and I said this already, but the benefits truly are the difference between pain and peaceful. And I think that is one of the things that is the purpose and intention behind hospice. It's providing end-of-life care. It's offering a soft landing to any human being that is dying. And we do everything in our power that we can. And if we can't, then we need to tap into our resources, and having those resources are so important.
Well said. Well said. Gabby, I think we can close it here because I think we've said all the things when it comes to continuous care. Just know that level of service is available to you through your hospice agency, or if you're an end-of-life worker on a hospice team, that is something that you might want to be part of. Some agencies have specific staff designated to be a continuous care team. So it's a complicated topic, but a really vital part of the care that hospice provides.
Absolutely.
So, Gabby, how can listeners connect with you and find your books? Do you have a new book out?
I do.
Let's hear.
Well, you can find all of my information on my website, thehospiceheart.net. And I just released my 10th book. And this one it's my grief poetry that I've been writing since my brother died. And it's about death and life and grief and just what it feels like to experience the loss of someone you love.
Beautiful. So they can order on the website, connect with you. You do a lot of writing. You've got a fantastic Facebook group that's very active. How can they find you on Facebook?
If you go to my website, the links to my Facebook is there, my books, my blogs, my classes, everything's there. The website is my hub.
I love it. Thank you so much, Gabby. Great to have you back on the show.
Thank you.
Thanks for listening to the Heart of Hospice podcast. Check out our sponsor in the show notes and please leave a rating and review on Apple Podcasts. We would appreciate it if you would share this episode with your friends and family and anyone who needs to know more about hospice. Connect with us on Facebook, Instagram, and LinkedIn. And remember, no matter who you are or where you are in your hospice journey, you are the heart of hospice.
This is the Whole Care Network. Helping you tell your story one podcast at a time.